We go to the prostate cancer part 18. Post-radiation recurrence. A PSA can increase during radiation, but this is generally not caused by cancer progression. PSA can be bonus up and down after radiation, and this is often benign process. Recurrence is present when any of the following criteria are found. If you have raising in PSA, the 2005 RTOG and STRO consonance defines biochemical recurrence after radiation with or without hormone therapy at the rate of 2 nanogram per ml or more above the nadir value of the PSA. So a rate of 2 nanogram per ml is considered as biochemical recurrence. This definition was constructed mainly as research tool rather than as a clinical guide for intervention. In general, a serum PSA should fall to low level following radiation therapy and should not rise on successive occasions, although allowance might need to be made for benign PSA bonus. A positive PSA biopsy more than or equal 18 months after radiations, local recurrent. So at distance, metastasis is detected systemic recurrence. This is considered as the recurrence present when one of the following is found. If you have raising in the PSA, or if we have positive prostate biopsy for more than 18 months after radiation, or if we have if we have the distant metastasis, is considered as recurrent. Before administering curative salvage therapy for radiation failure, local recurrence must be confirmed by biopsy, prostate biopsy. Seminal vesicles biopsy should also be performed. Curative salvage therapy might be offered when prostate biopsy show cancer and the cancer is localized. Okay, in this setting, standard treatment options include radical prostatectomy, chemotherapy, brachytherapy, androgen deprivation, and surveillance. Salvage radical prostatectomy. Salvage radical prostatectomy is seldom utilized because it's technically challenging and it has higher risk of complication than primary radical prostatectomy. So the complication of the salvage radical prostatectomy include rectal injury 6%, urinary incontinence up to 50%, and 20% require an artificial sphincter. Anastomotic stenosis 20 to 30%, erectile dysfunction more than 50%, as well as urinary incontinence. We have erectile dysfunction, which is 50%. Okay, but the urinary incontinence here, we need sphincter in 20% of the patient, and rectal injuries also occur in 6% of the patient, and stomatic stenosis 20 to 30%. This is a common complication with salvage radical prostatectomy. The ID candidate has a clinical stage T1 to T2. The Gleason score less than 7, PSA less than 10, a long PSA doubling time, and life expectancy more than 10 years. This is the ideal candidate for salvage radical prostatectomy. Appropriately selected patients, 5-year disease-free survival is 70%. Okay, we'll come to salvage chemotherapy. Salvage chemotherapy has higher complication rather than primary chemotherapy. Long-term complication after salvage chemotherapy include persistent urinary incontinence up to 22% of the case. Erectile dysfunction is very common, more than 80% of the case. Chronic rectal pain, 8 to 40% of the patient. And urinary fistula, up to 10% of the case. Okay, to compare salvage radical prostatectomy with salvage chemotherapy, we have this complication. Salvage radical prostatectomy, the complication include Let us compare the urinary incontinence, 50% in salvage radical prostatectomy. Okay, as you mentioned here, we have salvage radical prostatectomy is seldom utilized because technically challenging and has higher risk of complication than primary radical prostatectomy. So urinary incontinence 50%, erectile dysfunction more than 50%, rectal injury 5%, and stomatic stenosis 20 to 30%. Let's come to the salvage karyotherapy. The complications include persistent urinary incontinence up to 20% of the patient. And also the patient have rectal pain. That's patient with salvage radical prostatectomy have a rectal injury, which is 6%. Here, chronic rectal pain 8 to 40% of the patient. And here we have urinary fistula. In the salvage radical prostatectomy, have anastomotic stenosis up to 20% of the patient. Here, it is up to 10% the patient have urinary fistula. And the last and the most common with salvage karyotherapy, it's actually erectile dysfunction. It's common, more than 80%. Okay, this is a common complication. The ideal candidate meet all of the following criteria for salvage brachytherapy. Clinical stage T1 to T2 M0, M0, platelet score less than or equals 7, PSA less than 4, and also long PSA doubling time. Negative seminal vesicle biopsy after radiation. Seminal vesicle biopsy is indicated because the cancer in the seminal vesicles occurring up to 42% of the men who recur after radiation. Karyotherapy has not been shown to be effective and effective treatment for cancer in seminal vesicles. Life expectancy for more than 10 years. Salvage brachytherapy has higher complication rate than primary karyotherapy. Long-term complication with erectile dysfunction 80%, urinary incontinence 15%, urine retention 5%, rectal ulcer 4%, rectal complication require colostomy 2%. In appropriately selected patient, 5-year survival-free survival is 60%. Salvage high-intensity focused ultrasound data are limited, but 5 years disease-free is approximately 5%. Post-prostatectomy recurrence. Recurrence is present when any of the following criteria are found. Raising PSA, that's the ASTRO and AUA 2019 guideline divides the biochemical recurrence as the PSA is 0.2 nanogram, followed by subsequent confirmatory PSA 0.2 nanogram per ml. The NCCN guideline defines a biochemical recurrence as detectable PSA that's increased on 2 or more determinations. The ultimately of use of ultra-sensitive PSA, which detected the PSA at 0.01 nanogram per ml or lower, has not been established. Positive biopsy of the peripheral anastomosis regional, that's the local recurrence. A distant metastasis is detected as systemic recurrence. So this is the post-prostatectomy recurrence. Recurrence is present if one of the following is criteria are found: raising PSA, raising PSA, the recurrence, the chemical recurrence defined as raising the PSA is 0.2 nanogram. Okay, this is the first. Second, the Canadian mentioned that's increasing the PSA in 0.01. Also positive biopsy of the urethral anastomosis region. And distant metastasis systemic recurrence. 45% of the recurrence occur within 2 years of radical prostatectomy. 77% within 5 years and 96% within 9 years. Okay, so remember, 45% within 2 years, 77% within 5 years, and 69% within 9 years. A PSA recurrence after radical prostatectomy associated with higher risk of metastasis and death from prostate cancer. For the time of the PSA recurrence, the median time to detectable metastasis using the conventional imaging is 8 years, and the median time to death from prostate cancer is 13 years. Men with higher Gleason score and shorter PSA doubling time tend to progress more rapidly. Treatment options for local recurrence include radiation, androgen deprivation, and surveillance. Curative salvage therapy may be offered when clinical data and/or imaging suggests that the cancer is confined to the prostatic fossa. When salvage radiation is planned after radical prostatectomy, biopsy of prostatic fossa is unnecessary because the biopsy results do not predict the outcome of salvage radiation. Salvage external beam radiation reduces potency, but it usually has a minimal impact on urinary continence if administered long enough after radical prostatectomy. So the salvage radiation reduces potency and usually has minimal impact on incontinence. Salvage radiation is more effective and achieves higher disease-free survival when it is delivered at low PSA. The ASTRO and AUA 2019 guidelines state that salvage radiation should be administered as early sign of the PSA recurrence and ideally before the PSA rises to 1. The EAU 2021 guideline recommended offering salvage radiation when the PSA become detectable. The ideal candidate meet all the following criteria: PSA less than or equal 1 at the time of salvage radiation, long PSA doubling time, PSA recurrence more than 1 to 2 years after prostatectomy, and life expectancy more than 10 years. This is the ideal candidate for salvage salvage radiation. Okay, salvage radiation or external beam radiation. So this is the ideal candidate. The PSA less than 1 time of salvage radiation, long doubling time of the PSA recurrence more than 1 to 2 years after prostatectomy, life expectancy more than 10 years. Prostatectomy pathology show Gleason score less than or equal 7 and involve seminal vesicles and uninvolved lymph nodes. Mean BT1, T2, N0, M0. Salvage radiation does to the prostatic fossa should be at least 64 to 65 gray. So to the prostatic fossa, it must be in this 64 to 65. If possible, radiation should be administered when continence and erectile have recovered after radical prostatectomy. The role of androgen deprivation with the salvage radiation, ASTRO and AUA 2019 guidelines said that clinicians should offer hormone therapy to patients treated with salvage radiotherapy. The NCCN 2021 stated that the 6 months of castration with or without first generation anti-androgen can be administered with salvage radiation. If the PSA more than 1 at the time of the salvage radiation, then consider 2 years of androgen deprivation. Level 1 evidence support use of buclotamide 150 mg per oral query per day for 2 years in this setting. But castration might be alternative. So use if the PSA more than 1 at the time of the salvage radiation, consider 2 years of androgen deprivation therapy. Level 1 evidence support use of buclotamide 150 mg per oral for 2 years. In appropriately selected mean 10 years cancer-specific survival is 70 to 83%. Retrospective data suggest that the salvage radiation may improve the cancer-specific and overall survival. This is the end of part 18. Thank you.